So, Dr. Clayton Bell, thank you so much for agreeing to the podcast. We met recently in Zurich learning about cancer testing. It was great to meet you. I was really interested with your own personal story of being a doctor and then evolving your practice into an integrative and functional model. So I'd love to hear more about that. Should we just get stuck in and you tell me a few things about how you got here?
Yeah, I'd love to. And thank you so much, Dr. Thompson. I really appreciate you inviting me here. It's an honor to speak to you and, really everybody over in the UK predominantly and integrative medicine. I love what you're doing over there and really, bringing it forward, because a lot of the people that are probably, watching this or listening to this are in a similar situation to what I was in. I had, your standard Western medicine, allopathic training with, medical school. And, of course, in medical school, it's great because we get the basis and the foundation of, biophysiology and, pharmacology and all those kind of things. But they really, at least in the US, they don't really teach us much about healing, and
Mm.
the inner landscape. And so my journey was fairly, I would say circuitous and serendipitous in nature. I had actually gone down to Haiti to do international development for 2 years after medical school prior to starting residency. And I was helping down there after the big earthquake in 2010. Um, One of the big things that I took from that, besides just like how resourced we are, in kind of Western countries, was how much education played into illness. And the same lack of education that was inherent down there with things like germ theory and cholera were not so different than what I was seeing with my patients in residency that were suffering from high cholesterol, hypertension, diabetes. They had no idea that nutrition had any impact on those conditions whatsoever. Um, so it really, what I found is when you, modified their diet and gave them different lifestyle interventions, they were able to, drop medications instead of adding medications, so on and so forth. And so that became a fairly intuitive way. And it just seemed obvious that we would want to go after like root cause as opposed to just prescribing more and more pills. And don't get me wrong, I still use pharmacology and medications in my practice, but it's a tool, right? It's not the tool or the only thing. And so after residency, I went on to do a fellowship in integrative medicine at the Kansas University Medical Center because at the time they had the really the strongest orthomolecular medicine, functional medicine, hands-on clinical integrative medicine fellowship in the country. And then I got recruited to the University of Tennessee Medical Center to work in their cancer institute and bring functional medicine and integrative medicine at the Cancer Institute. And that was very eye-opening for me. My grandma had cancer and had passed away from cancer years after her original diagnoses. And I remember, I don't know what the primary was. I was too young to know. I just remember them saying it was in her bones. So,
Mm.
obviously it was metastasis from somewhere. But I remember they told her that her prognosis was about 6 months, and she lived probably another 10 years. We watched wrestling together. She did, two-stepping, she danced. She had raccoons in the backyard, did woodwork. She climbed over the barbed wire fences to go, catch catfish into her 70s and 80s. And so I think it showed me, even like on a subconscious level, at a very young age, how much the person and the spirit can influence the disease state. How that's just as important as the diagnoses. Honestly, probably way more important. And so that kind of laid the groundwork. And then throughout my medical training, I kept finding subpopulations of patients that I wasn't able to get better with, say, family medicine. So I went to integrative medicine, and a certain subset of people I couldn't get better with integrative medicine, right? So then I went to functional medicine, and a certain subset of people in functional medicine I couldn't help get better. And then I found out a lot of them had like Lyme, and a subset of people in Lyme I couldn't help get better. And I found out they have mold, and now as I dig into the mold, the ones I can't help get better will have like MCAS or multiple chemical sensitivity or, neuroendocrine hormonal, dysregulation from these exposures. So anyway, you know how it is. When you get into medicine, it gets fun eventually once you get past all the base stuff, and then becomes more theoretical in nature, and you can really be really artistic with it, I feel like. And that's kind of the stage that I find myself in now is, every single patient has a very much a personalized treatment plan, based on them, their condition, their desires, their capacity and abilities and resources and motivation. And yeah, it's like it's really feels like a kind of a four-dimensional art project with people, that we're co-creating together. So medicine is really fun for me right now. And I hated medical school because I just hated studying in the library all day. It felt so lifeless. And now it just feels so vibrant. So I'm just really lit up with it, and going to things like we did with the RGCC conference in Switzerland and getting to speak there about the personalized cancer testing. It really does it for me, So
Mm.
I think I'm as excited about it as the patients are, during the
And
appointments.
And with the master's program that NCIM runs, we were just talking with year two about the art of holistic consulting.
Mm.
And, I like to sing jazz. And I was talking about how, you need to learn the song and you
Mm.
learn the structure and then can start to move off it. And I think that's one of the joys for me of integrative healthcare is I don't get bored. I never did get bored in medicine because I loved to see each person as an individual. But I think it brings me more hope, as I
Mm.
have more knowledge. And we'll get on to cancer testing in a minute. But because I realized that some of the areas I stepped away from was actually because I didn't really know about them or understand them. And I think I've been a reluctant adopter of testing,
Mm.
and I know that functional medicine brought a lot of testing because one was looking at a cellular level of health. And I think I, like you, was always interested in healing. I didn't really realize that I was a healer because I loved medicine, but I just found myself uncomfortable not being able to go deep.
Mm.
And I got told off by a nurse so I trained in palliative and supportive care, and I got told off by the nurse on the ward who said, "Would you stop talking to people and give them diazepam? It would make the ward round quicker." And so I want to pick up on a few things. We've picked up on just our journeys, but tell me a bit more about healing for you and how you see that.
Yeah, absolutely. So, in alignment with kind of what you just said, you talked about jazz and then playing off and being creative. I also feel like, as healers, whether you want to be or not, right? Like we're stepping into that realm somewhere between, physician, shaman, priest, healer, witness, right? Like because people are literally bearing their souls to us and telling
Yeah.
us things that they've never told anybody, like literally, I've had 80-year-old women tell me about sexual abuse that happened in their childhood that their husbands of 50 years don't even know about. And
Yeah.
so when people feel safe, they understand that the more they can open, the more that we can help them in that healing process. So one of the big things that I would say that I'm learning, and it's a walk, right? Like I don't even pretend to be anything close to enlightened or have it figured out. But as I continue to walk further and further down this path, one thing that really sticks with me is you can't give what you don't have. And so I think one of the most important things all of us can do is really doing just a super deep dive into our own souls, and looking at our own like shadow work and our own traumas and, our own little boy or little girl inside that's driving the show, because ultimately those are some of the same, um, shortcomings, inhibitions, roadblocks that our patients are also experiencing. They're going to hold them back from their healing journey. And so the more really just embodied that we are as healers, patients pick up on that. It's
Mm.
very, energetically, right? You can tell, and even if you think about like, heart rate coherence as well, like there's electromagnetic field that's generated by the heart that there's actually, machines now that can pick up on, that the heart waves will emit at least several feet away, and someone's brain waves will sync to another person's heartbeat. So if our heartbeats are in coherence, literally people around us are going to, basically co-regulate off of us, just like an infant's going to co-regulate off of a mother. So if the
Mm.
mother's regulated in her nervous system, the baby's going to be more calm. And if the mother's dysregulated, obviously the baby's going to be, dysregulated as well. So I think that's an important aspect of the healing process is we need to be healthy as well.
Mm.
And, a lot of times that can be challenging in the system, and I'm less familiar with the British healthcare system, but I know that at least like in residency and the way that most of us get taught in the US, if we come out in a typical practice that takes insurance, we're probably going to get stuck with 20-minute appointments. And that just doesn't really allow for a deep dive into a person's history, all their concerns, all their medical diagnoses. And so I think what happens is we get kind of stuck with treating symptoms or symptom clusters. And so that's where I think a lot of like just to throw the med at it and you got to see the next person and move on. And so I think a lot of it is, for healing to happen, you have to really cultivate an environment for success, kind of like the weight loss patients. If someone wants to lose weight and there's a bunch of candy in the house, like willpower is essentially an illusion, right?
Mm.
But if it's like out of sight, out of mind, and you don't have access to it, well, then you're much less likely to say junk out on For me, it'd be things like granola, you know what I mean? Like at night, something crunchy and carby. So if I don't have it in the house, it's not going to happen. So I think it's kind of the same way for these patients is we really have to sculpt their environment for success to where doing the easy thing is also going to facilitate the healing response and take them where they want to be step by step. So I'm a big fan of like, what's the lowest hanging fruit? What are
Yeah.
we going to get the most yield from that's the easiest for them to find success? Because if I give someone the perfect treatment plan with 10 things and they feel overwhelmed and do any of them, it's worthless, you know. But if we can just start small and then let them gain their confidence, feel a little bit better, their resiliency and their capacity shifts and changes for what they can handle. And so I think I think it's a journey that we're on together.
Yeah, it is. And, that journey took me a realization that I was offering a safe place because I couldn't always find it within myself.
Mm,
And so, quite later on in life, I've been digging deeper to look at that thread of trauma
mm,
um, that made me very sensitive and aware and able to lean into others' distress. But of course, at what cost for me energetically if I
sure.
haven't understood that?
Mm,
So I think, again, with the master's program, we talk about the healing environment. We talk about self-care, although it is a journey. And, like I even noticed you saying, well, I couldn't sort people, so I did this, couldn't sort people, and I'm wondering, it's quite tough to get to that place also in yourself where you realize, actually, I might not be able to sort this one,
yeah, yeah,
despite everything,
sure.
all that I know, it's like it's a mystery.
Yeah, I 100% agree, and I think that's one thing that patients really appreciate and respect is, sharing knowledge and expertise that we have, and then when we don't know, we just literally tell the patient, "I don't know," and I
Yeah,
can try to find that out, or, like, let me refer you to somebody, that's what they do every day,
yeah,
like, this happens to me all the time, I don't know about you, but because I do a lot of integrative oncology where I'm providing, say, integrative and functional medicine testing and strategies and therapies for people with cancer, they want to do all that, and I always am having to refer them back to their oncologist or their surgical oncologist or their radiation oncologist and say, hey, like, I'm your functional medicine doctor. You don't want me doing your surgery. I am not trained in that. I'm not scrubbed in a surgery in 15 years. I'm
mm,
not the person to tell you the cost benefit, risk analysis of a specific chemotherapy regimen. Now, I can test your cancer cells and tell you which ones are going to be most effective in a three-dimensional petri dish, just like you would a urinalysis with, antibiotics. Now, I can do that for you. And then we can give that to your oncologist. And then you can make a joint decision on what chemo regimen works the best. And then I can use that same type of information for natural agents, right? Like, melatonin or vitamin C or vitamin D or, maybe some off label drugs, so on and so forth. And that way the plan is like individualized and not like, well, I read on this blog, so and so took these meds, and I read on this blog, so and so took these herbs. And right. So, I feel good about that. But then I'm also very quick to be like, hey, like, this is not a, alternative to, this is an adjunctive of, an addition to. And then in some patients too, I think we're just there to hold the space. Like I have a lot
mm,
of patients that might see me with, a stage 4 cancer, and I'll tell them, hey, like, we'll run the tests, we'll do the therapies, and I think this will improve your quality of life. And I have every, intention that it will improve your duration of life as well. But, please be aware that I've taken care of thousands of patients and I've probably seen less than 5 spontaneous remissions. You know what I mean? Where people just kind of miraculously got rid of their cancer. And people have this really, with these really advanced diseases, sometimes they have that false notion, and they think if they meditate it out or pray it out, it'll disappear. And I just haven't seen that to be the case. So the
yeah,
people that I've always found, at least with cancer, since that's kind of where we met, was at a cancer conference. But the people that I've always seen do the best are the people that take the best of both worlds.
yeah,
They modify their nutrition, they take proper supplements that are evidence based, evidence informed. They do the shadow work, they do the psychosocial, emotional trauma work, right? And they do the standard of care therapies that are evidence based as well.
yeah.
Those people almost always do better than if you just do Western medicine or if you just do alternative.
Yes,
So,
I think that's really coming into view now, and the way that the science can help us, because I'm just studying Volta Longo's work around the fasting
mhm.
mimicking
Oh, yeah,
diet, and
beautiful.
it's really interesting to see how it enhances
Mhm.
cancer treatments, including immune therapies. But go alone, they've done my studies where you just use fasting. if you just use chemo, the mice tend to get pretty ill.
Mhm.
If you just use fasting, it's not enough. But if you put them together,
Right.
that's where the magic is, because you're kind of doing two very different things. But if you don't activate the immune system, how can and what I mean by activate is resource it, build resilience. So
Mhm.
it can respond to the immune therapy. So I want to ask my question now that we've moved into integrative oncology, because I was really struck at the conference when you spoke about getting it from your oncologist colleagues' mindset, and
Mhm.
I felt that you really showed a lot of compassion, and I think this is really important to why an oncology colleague might find it difficult
Mhm.
that their patient is getting testing. Do you want to speak a bit
Yeah,
about that?
I'd
Yeah.
love to. I'd love to speak to that. I think that's such an important thing because I feel like I don't know how things are in the UK, but I know at least in the US, things continue to become more and more polarized. Now that could include people's views on all kinds of topics, right? Um, but it also happens within the medical communities. And instead of like us all working together and pooling our resources and expertise, what happens is there tends to be this chasm, especially when it comes to, like traditional or traditional medicine really is like, Ayurveda and traditional Chinese medicine, right? But so I call it neo-traditional, so like, the current standards of care that have really just come about in the last 100 years. So the kind of the neo-traditional therapies versus the complementary or integrative alternative therapies, right? And so it becomes kind of this binary thing when really it's just a spectrum, right? And so I think one of the biggest disservices I see is like the distrust amongst the community of healthcare professionals versus us all having more of an open dialogue and transparency and being, collaborative in nature. And I think I have a unique perspective by working in a cancer institute for 6 years and being very good friends, personal friends as
Mm.
well as professional colleagues, and sitting in on like weekly meetings with the whole cancer staff all got together for an hour on a Friday morning. And we just talked about breast cancer patients together. And I talked about turmeric and they talked about surgery and they talked about, what the biopsy results showed, and so we all contributed and that's basically built trust with each other. But I'll never forget one day we were having a lunch together and I was sitting with like three of my oncologist friends and one of my colleagues, and he actually had some integrative medicine training when he was in his fellowship, I believe at Jefferson. He looked at me and he said, basically he's like, I have a hard job. He's like, to tell you the truth, I'm just trying to keep from killing somebody every day.
Mm.
And just the gravity of that really landed with me because obviously he wasn't killing anybody. They already had cancer and he's trying to save their life, but he was taking on that personal responsibility. And I just thought to myself, God bless, how hard must that be to be an oncologist where people are like, at least I get to like help them with their nutrition and improve their quality of life, and like help them focus on things that bring joy and love to their life. And so, and my outcome's not even specifically on if they live or not, right? It's really just like enhancing their life force, for however long that lasts in whatever magnitude that is. So, I just thought the gravity of that is so heavy. And in addition to that, what I started to see was, and I think this is the point you're talking about, all doctors are basically indoctrinated in the belief that we're supposed to have the answer.
Mm.
And that's just not true. Like, obviously, like if we knew 1% of the universal knowledge, we would be so much brighter than Einstein ever was. There's no way we can attain that, especially now. I mean, there's more journal articles that are being published every week than probably existed, 50 years ago. And so it's just unbelievable the amount of information out there. Now we have tools like PubMed and AI, that can help collect all that research for us. But still, I mean, even the research is conflicting in nature. And you even have editors of like the Lancet and the New England Journal of Medicine basically saying that half of the published research, even in their journals, is BS. And that's kind of like it's just not factual. And so with that, it kind of brings a point. Well, what is reality then, right? Because the bedrock of our reality is essentially science. But if science is malleable, you know what I mean? Like, then what are we even talking about here? So I think just the compassion that we need to share with our colleagues, and then also understanding the concept of psychological dissonance. And this is what I spoke about at the conference. For instance, if let's say I'm a functional medicine doctor and I'm the world expert in, let's say, IV vitamin C combined with intermittent fasting. Okay. Now, let's say that I've built my entire career off of this, and somebody comes to me with an opposing worldview or a research paper that says something different. The natural tendency to that is to basically be dismissive of
Mm,
new information. And it's really a psychological defense mechanism, especially if our ego is highly built upon this premise. Easy examples of this would be things like, I don't know what religion you grew up in, but let's say you grew up in a religion. Like I grew up in the southern United States, which is very strong Bible Belt. And it's not only are you Christian, it's like, which church do you go to? Oh, I got a Church of Christ. Which one? The first or the second Church of Christ? You know what I mean? So it's like, and if you go to Baptist or Methodist, you know what I mean? Like, you're not one of us. So that was just the social programming that I grew up with. But if you were to go to somebody and say, you know what, that Church of Christ thing, that's not true. There would be this huge like attack, right? Like that you felt on a visceral level because the foundations of your reality were built upon those perceptions and those storylines, right? And they created basically the scaffolding for everything else to lay upon. I mean, we got indoctrinated in Bible stories as I was a child, right? Those are some of the earliest stories that I understood about the way humans interact with each other about. And so nevertheless, you come in and start talking about Buddhism or Hinduism or Taoism or paganism or anything else. It's just a complete like, whoa, 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 heathen, not true.
mm,
You know,
yeah.
discredit that person, take away their medical license. And it's kind of the same way if you go talk to a vegan about going keto, or you talk to someone who's really big on a ketogenic diet about going vegan. Obviously, there's just going to be a huge like defense that comes up because it's a violation of that person's, basically foundation of truth and reality. And so I think that's what happens. Like for instance, we were at the RGCC conference, which does really the most personalized cancer testing in the world. And I was speaking specifically on a lot of the Onconomics Plus tests, which shows like 70 different gene drivers of that person's specific circulating tumor cells. And like I said, which chemo drugs work and which natural agents work, so on and so forth. And what I have found is some oncologists think it's the best thing since sliced bread. They're like, oh my God, it's amazing. And let me try to incorporate this if I can kind of edge around NCCN guidelines, or if a person has stage 4 and they've already failed 2 treatments, everything's open, everything's game at that point. There's no like medical litigation that the oncologist maybe has to worry about, right? Because I mean, let's be true, that's part of it. It's, at least in the US, cancer is hugely litigious, and if you give someone a therapy and they have a bad outcome and a family member's upset about it, especially if it's not standard of care, you're medically liable, right? And you might be putting your whole clinic on the line and your family and your license, your ability to provide for yourself. Um, and so I think what happens is you present new information that might be something that's outside of someone's previous training. And of course, there's like a natural defense to potentially reject it or question it. So I always tell my patients or other practitioners, hey, if you meet resistance, just like understand it, welcome it, know where it's coming from, and don't
Mm.
don't take it personally, right? Like we all do it just in different aspects. So I think that really takes a lot of the judgment and kind of defuses the situation, if that makes sense, because it is such a highly emotionally charged topic, like Lyme's another big emotionally charged topic in the US.
Yeah.
Some practitioners think that it's in very isolated regions and you treat with 2 weeks of antibiotics and that's it. And then others of us have realized that it's totally endemic, you know what I mean, across the country. And almost everybody has, antibody immunological markers to it and the co-infections. It's just a magnitude of how much it's affecting their system.
And I just want to come in to say that, you're making me realize something really important, which is the more that we drive a kind of say like a monologue of something we
Mm,
believe in, I'm using that word mono, it's much harder to flex out into a broader model. And that's what I've loved about integrative healthcare.
mhm,
Because I kind of came through the conventional lens. I was training in oncology, and I didn't have much support. I remember one night not giving folinic acid to a young man with a teratoma, and this sense of terrible responsibility. And I
mm,
went on the ward the following day. Oh my God, have I killed him? But luckily, I hadn't. Then palliative care, which broadened it
mm.
for me, but
Beautiful. Yeah.
then medical homeopathy, which as a model of understanding, I got very involved with. And then I even had to let go of that.
Mm,
Not that I don't have expertise around it, but
sure.
just letting go into realizing, okay, if someone's going to not want that, or it's going to create more division, then let's let go and let's use something that we can join. I talk about Sophie Savage used to talk about the patient being caught in the crossfire.
Mm,
So just coming back to the cancer testing, I think it has been the public that has driven the dialogue, because from a from an individual's point of view, their thinking is 2 things. Don't we want to understand everything we can about the cancer and my immune system? And also, don't we have to be sure that these treatments are working? And also, the question that was always asked to me is, can you now check to see if there's any cancer
Mm,
active in my body? So,
yeah.
could you talk to us a little bit initially just about circulating cancer
Hmm.
cells and how
Sure.
you might use that in practice?
I'd love to, because this is something that I had no training in and no understanding of. And so let's just come with a perfect example. So you have a patient with, let's say, prostate cancer. Well, at least you think they have prostate cancer. There's like let's say, a 2 centimeter nodule in their or in the prostate area. PSA is elevated. Like, let's say it's like at a 10. The patient does not want to get a biopsy, and I'm always okay. Understand you don't want a surgical procedure. Please share with me why you don't want to get a biopsy. What I always hear, I don't want to see the cancer. Same way
Mm,
on a breast lump. Breast lump is
mm,
there. It's found maybe on a physical exam or like a mammogram, or and then confirmed on ultrasound and MRI. And the patient will not get a biopsy. Why don't you get a biopsy? Oh, I don't want to see it. I don't want it to spread in my body. And what I will tell you definitively, 100% without a shadow of a doubt, by the time any tumor shows up on a mammogram, ultrasound, MRI, CAT scan, PET scan, there are already thousands of circulating tumor cells in the body. I mean, if you think of it, it's a very obvious thing. There has to be blood flow there for the tumor to grow. Blood flow has to leave, otherwise, it would just grow into a giant hematoma, right? And so, of course, cancer cells are going to shed off of that and circulate in the body. And so with so that's great information. So first of all, that really reassures people. Oh, I can get the biopsy now and actually see what's going on. You know what I mean? Is this
mm.
benign? Is this like a very aggressive tumor? You know, is it ER positive? Right? You know, and so because it makes a huge difference on therapy, because you can't really treat until you know what you're dealing with.
Mm.
And so, but when we check, so that's why we do the RGCC testing. And there are other tests out there, like in the US, one that I see a lot is Signatera, which is
Yes.
fantastic because insurance covers it. And you can do like circulating tumor DNA, you know, every month, which is great. So I love that for patients. And that's a very practical thing to do. And I'm 100% for that. So some of the issues though that come with that, and this is not a knock on Signatera, I think that's fantastic and I love it. I love how it's FDA approved. But what happens a lot of times is patients will be even like, um, let's say through their treatment course, and they'll have a 0 score on that and they think they're in the clear. And then every single time we run like an OncoTrace or an OncoPlus on them with RGCC, and we always find circulating tumor cells. And so what I tell people is, if you've ever been diagnosed with cancer, you have circulating tumor cells. The question is just how many, and then let's evaluate them to see basically how aggressive they are. Like what's their OKT4 or SOX2, you know, or NANOG, you know, what are their stemness genes, so that we need to be aware of, you know, like what are the chances they're going to actually like metastasize and set up shop again. Because that's what kills people, you know, unless it's like a pancreatic cancer or, you know, some other like tumor that, you know, they didn't catch till stage 3 or stage 4. You can almost always initially treat the stage 1 and stage 2 cancers with, you know, surgery and so on and so forth, you know, chemo, radiation, what have you. But the problem is they come back, and that's when people die, you know.
And
Yeah.
can you just talk to us about that terminology? Kind of slow it down and
Yeah, for
imagine
sure.
someone doesn't know anything. They don't know what stemness is. They don't know what
Yeah.
two is. Just because I think that's one of my learnings, and I'm really interested. So just say a little bit more about how we define the cancer cell.
Yeah, absolutely. So there's going to be the primary tumor, right? And that's what always gets addressed in oncology and Western medicine, is always the focus on the tumor. Which is appropriate. We have to take care of the tumor, right? Um, if you don't, and this is one thing I always advise patients on too. Like, it's very rare that I've ever seen patients do completely complementary, alternative, or integrative medicine to get rid of a primary tumor. Very, 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 like one in a blue moon, exceedingly rare. Even if they go to places like month-long intensives out of the country and do all kinds of different invasive therapies and IVs and all that, which I think is great adjunctively, but still, it almost always still progresses. Maybe they kick the can down
Yeah.
the road for a few months, but they almost always have to come and eventually do surgery, get it cut out. So, but what happens is that's the primary, and that's really all that gets focused on, unless you have no metastasis, right? And if you have metastasis to your spine, you might get like radiation to the spine to basically kill that lesion, so it's not causing pain and so forth. And then chemotherapy is really the one agent, right? That's going to be systemic in nature, right? Chemo is going to go throughout your whole body, kill the cancer, and it should kill the circulating tumor cells as well. But what basically happens is these CTCs, circulating tumor cells, are basically just like daughter cells that have split off the cancer itself, and they just circulate in the body. And that's how you get metastasis. They set up somewhere else. So, for instance, prostate cancer is classic for going to the bone. And then a man will show up with bone cancer, you know, a couple years later. And that's obviously much, much harder to treat. circulating tumor cells themselves, let's say they're like dogs. What I tell patients too is, let's imagine that we're at our house, it's dark outside, all the windows are shut, and we hear dogs barking. Well, we really don't know what kind of dog it is. Is it a pit bull, which is more concerning? Is it a schnauzer? Is it a Pomeranian? Well, what is it, right? Because I'm very much different concerned if it's a Doberman Pinscher versus if, let's say, it's a oh, I was trying to think of that little dog my parents used to have. It's so cute. And like a little lap dog, say a Maltese, or I'm blanking out on the other kind of puppy that I'm thinking of now. But anyway, some are cute and fuzzy, and some are like really dangerous. And so there's actually testing. You can actually literally look at the circulating tumor cells, and you can actually look at some of these different tumor genes, these circulating tumor cell genes, and it can actually give us a read on the aggressiveness of these, which is phenomenal. And then OKT4 and SOX2 and NANOG are just some of these like stemness quality genes. And stemness just means that it's basically a cancer stem cell. So it can basically set up and create another tumor down the line somewhere else in the body.
We had an oncologist present in our recent, we just had a day on testing in integrative healthcare and the ethics of knowledge. We really wanted to look at, knowing when you don't want to know and not knowing when you might want to know, and can you do anything with it anyway?
Beautiful.
But
Yeah.
what was interesting is that the UK now have testing, but they don't define the cell in that way. And I just wonder about why the conventional teams aren't doing that, because it would be very helpful to know who to put under more surveillance, who
Mm-hmm.
to have those conversations, because I see some people and they're told, you've got a 90% chance of your cancer coming back, but actually it doesn't come back, So, but that's a very powerful negative messaging. So why aren't conventional teams using these cancer tests more?
That's a great question. Now there are some out there, right? Like the oncotype. Like a
Yeah.
lot of my colleagues I see now getting oncotypes from with breast cancer, and that risk score tells them what's the benefit of chemotherapy going to be? Do they really need chemo or not? Which is beautiful, right? Because if
Yeah.
you're not going to get a benefit, then obviously you don't want to give chemo or take it.
Yes.
So that's huge. So I do see that. I think a lot of it comes down to like what's FDA approved to, and then what are we taught? What are we indoctrinated with? The
Yeah.
the the cancer testing that I'm talking about is very cutting edge, but it's not a insurance reimbursed FDA approved test. So patients are paying out of pocket for it. Most oncology teams are not taught about it in medical school. So once again, it comes in as this idea of is that real science, right? Even though it's created by a cancer lab that has all the credentialing and all the CLIA certifications and so on and so forth, right? And I think I think it kind of falls into that idea of it's new information. What do I do with that information? And I think that's what happens in just all honesty. So I'll put myself in someone else's shoes. Let's say I'm your oncologist. You come to me, you have stage 3 breast cancer. In the US, I have NCCN guidelines. If your cancers, let's say, intraductal carcinoma, ERPR positive, HER2 negative, let's say it's KI67 of, 50%, what have you. I have basically a protocol that I follow chemo-wise for you. Now, let's say you come and give me and a test that's not FDA approved, right? And then it tells me that actually the drugs that I'm supposed to give you are not going to be effective and something else is. I'm putting myself at a huge risk by following your personalized treatment plan versus giving you the NCCN guidelines are kind of a one size fits all. So not only am I putting myself at risk medically and my medical license and getting sued by the family if we have a bad outcome or you, but also I don't have time for that. I
Mm.
got patients to see, you know,
Yeah.
um, I don't have time to give you your own personal therapy. It's like, you've got breast cancer, you get this. Next person, please. And it shouldn't be that way. But I mean, the truth is, if you have to see so many patients in a day and you just literally don't have the physiological bandwidth and time to spend with people, and like, so we're in a super privileged situation. I spend 60 minutes with every single new patient. The only way that I can do that is to have them literally pay cash for that appointment. If I tried to use insurance, it would be 15 minutes. You got to go because I cannot get the insurance reimbursement to keep the lights on and hire my staff. And
Mm.
so I think that's a lot of it, right? Is that physicians don't have the time to give you a personalized protocol. I mean, if everybody started getting personalized cancer therapy, it would disrupt the entire cancer treatment system grossly. You would have to restructure the whole thing. And so that, I mean, not that that shouldn't be done, but, or but I'm not making a judgment call there, but I'm just saying like that's very inconvenient.
Yeah. I think these are lots of really important reasons. How do you personally get around this whole potential for someone to sue
Sure.
you?
Yeah, that's a great question. So I'm really lucky because I'm not an oncologist, so I don't have to make those hard calls. So I'm in a sweet spot, right? Because I'm working with people that are either actively going through cancer, so I'm trying to mitigate their side effects. So, for instance, if someone's on chemotherapy, like you talked about the Walter Longo, like the mimicking fasting diets, which he's really famous for, but I'm trying to get patients. So, okay, let's fast 24 hours before and after chemotherapy to mitigate the side effects, right? Let's try to get your body healed up, post radiation. And then what I'm really working on is okay, after you have your definitive therapies, surgery, chemo, radiation, let me work with you to make sure you don't get it again. You know what I
Yeah.
mean? And so I'm kind of in a lucky spot there because I get to improve their nutrition and decrease their stress and help them work on past traumas and improve their exercise routine and decrease their toxins and make sure they don't have underlying stealth infections like Lyme or EBV and make sure they don't have mold exposure that suppressed their immune system that left them vulnerable to breast cancer in the first place. And so I don't have to make those hard calls and give the chemo and that kind of thing. I
Mm.
get to work with the natural agents after they're done with their definitive therapies and put them basically on protocols. Okay, for this 3 months, we found that, let's say, vitamin C had a 30% kill rate after one dose for your circulating tumor cells. Vitamin D had, say, a 25% kill rate. And then let's say quercetin had a 20% kill rate. So let's do this for 3 months. And then in 3 more months, come back, and then we're going to rotate them to something else because we always see high multi-drug resistance with these like efflux pumps. And so whatever you use, whether it's, carboplatin or IV vitamin C or frankincense, it doesn't matter. You're going to kill a subset of the cancer cells. And then the cells that don't die are the ones that are going to like basically reproduce and split, not reproduce, but split their genetic material. And they're going to have chemo resistance to whatever you've been using. And so for me, I'm not in that situation that I have to make that call against, the oncology NCCN guidelines. But the way that I use it practically with patients is I try to form, and this is a key for all your practitioners out there that are not oncologists but work with oncologists. I try to create a very harmonious, respectful, collaborative relationship with that provider to where there's a
Mm.
mutual trust and understanding. And they know that I'm very science, evidence based, very sound, very safe, um, very passionate, practitioner who wants the best for my patients, but I'm also not selling them on an ideology that's unfounded, if that makes sense. And you'll see that out there too, right? And
Yeah.
so I think trust is the number one thing. And then transparency. So what I also do is even if I don't know the practitioner, like let's say the patient's in the state, I'm like, hey, do you want me to share this? Can I send a fax of this, these results? And can I send a fax of my medical note over to your oncologist? And some patients actually don't feel comfortable. Some patients literally will be like, no, you cannot send that to my oncologist. They will
Mm.
berate me. But I always tell them, no, like they need to understand what you're doing. They need to know everything that you're doing so they can help you better, right? Even if they don't agree with you, you're still the one making the call. Like let's try to create more of a collaborative effort. So basically collaboration, sharing information, transparency, and then trust. It's really just building rapport. And then
And tell us about how to build trust with your colleagues, because obviously when you were working
Mhm,
in the cancer center, that was ideal. But now that you're in private practice, how do you build trust? I mean, I'm hearing that you'll do a letter, a
mhm,
summary. I think these things, trust and transparency.
mhm,
We have a very vibrant cancer service, and we at the moment only send letters when patients allow us. But
mhm,
I'm thinking of pushing a bit harder to say, look, what you're doing is evidence based, particularly
mhm,
say like with mistletoe that we deliver a
mhm.
lot of. Let's share it. But
Yeah,
I'd love to know the practical elements for
that's a
building relationship.
Yeah, that's a great question. So it's harder now. Like obviously it was so much easier when I was in meetings with people every day and like we had that face to face. It's much harder now because I actually do all telemedicine. I take care of patients in 7 different states. And my clinical practice really now is essentially niched on cancer, Lyme, and mold. And
Mhm.
my patients are from very different places. So obviously I don't have as tight a relationships with the provider in Florida or Colorado or Texas, even as I do in Asheville. So I try to do really clear documentation where a
Mm.
provider can read my notes. And then especially one thing that I do is I actually create a personalized wellness plan. And so at the end of every single note, this is like totally basically a bullet pointed summary. and it's basically has subheadings of nutrition, activity, stress resiliency, sleep, environment, relationships, labs and testing, imaging, medications and supplements, and then like if I do the RGCC, like the testing of the therapies, and then follow up. And so that's because, like, if a doctor sends me a note and I got to see somebody, like, I don't have time to read the whole note. But if I have like a boom bullet point and I can scan it in 30 seconds, I get a better gist of what's going on. And so I
Mm,
just try to make it like very accessible to the patient, accessible to the other providers, and then also it's word of mouth, right? Like I have really good results, and my patients love me, and I feel like just your reputation is gold. You know what I
yes.
mean? And your reputation spreads, and it doesn't happen overnight, but it happens over time.
Yeah.
Patients talk, physicians talk. So I just feel like, if you, my grandpa told me one time, he said, what did he say? He goes, don't ever lie, and you don't have to remember what you said. And I always thought that was really good because it's kind of like, I don't always remember what I tell patients, but I try to write everything down. And then if I'm just working in full integrity, I don't really have to worry about it because there's no way that you can retain all the information that we're, basically distributing on a given day. But if I'm always, not, I'm going to say in the right because, that's, you know, right is subjective. But if I'm doing my best and I'm acting in full honesty and transparency and openness and love and so on and so forth, that comes through. And so
Yeah.
if I make a mistake, I make a mistake, but it's
Mhm.
not punitive in nature.
Yeah, and I think you were saying this at the beginning, patients are picking it up.
Hmm.
They're sensing your compassion, your integrity, because they get a lot of BS out there, and so they kind of they're honed to pick it up. Well, thank you so much. And it feels like you're doing amazing work for a lot of people out in America. It's great for us to, get a different continent and, what's happening for you, how to compare it with the UK. But I think there's no doubt about it, integrative healthcare is growing on both sides of the Atlantic. So it's been great to meet you. Good luck with everything,
Likewise.
Clayton.
Thank you so much. Honor being
Thank
here.